Okay, so the second case this morning is a 78-year-old lady, and she's got quite a long and complicated history of rheumatic heart disease. She had rheumatic fever as a child, and she actually had her first intervention when in 1978, back in 78, so that's over 30 years ago, when she had a surgical mitral valvotomy and of her mitral valve to relieve the mitral stenosis. And she did very well for many years after that, but in 2006, so 6.5 years ago, she came back with rheumatic aortic valve disease, and she's had an aortic valve replacement with she's got a mechanical prosthesis, and we'll see that on the echo in a minute. Unfortunately, she's now developed mitral restenosis, and her mitral valve is now felt to be, it's moderate to severe stenosis, and there's at least probably mild to moderate regurgitation. She's been assessed recently by her surgeon who did aortic valve replacement, who feels she's now a very high risk for what would be a third operation. And we're going to try and relieve this stenosis, at least partially relieve her mitral stenosis, with a balloon valvuloplasty instead. And this is very much a palliative procedure just to try and improve her well-being. There are a couple of complications. So far, she's got atrial fibrillation. That's obviously very common for people with rheumatic heart disease, and she's been in atrial fibrillation for many years. And she's developed pulmonary hypertension as well. So she's got significant pulmonary hypertension as well. And we'll see her pulmonary artery pressure in a minute, albeit under anaesthetic, and it'll be a bit lower than we would normally measure. She's a couple of comorbidities as well. She's anemic, this lady. She's an insulin-dependent diabetic. She's been on insulin for many years. And she has significant renal impairment as well. She's got an estimated GFR of just 38. For these reasons, we're doing this procedure under general anaesthetic. We're planning not to use any X-ray contrast media at all. We'll be doing no injections, but we do have transesophageal echo monitoring, and we'll be using the TOE to guide pretty much the whole of this procedure. And we'll talk through some of the advantages of that as we go along. But I think it's a very good way of monitoring the transeptal. So we have a safe transeptal puncture. We'll see that very clearly, hopefully. And it also avoids the need for giving X-ray contrast to monitor the mitral regurgitation. So we'll go across and have a look at the TOE next.